So if you take care of critically ill patients, this is an ECG that you simply have to recognize immediately and treat at once if you are to save the life of the patient. And the problem here is that if you misdiagnose this and give something that you are actually not supposed to give, the patient's outcome will be quite fatal. So the biggest mistake that people make with this ECG is that they will mistake this for ventricular tachycardia. This is not ventricular tachycardia, and I'll explain why. So there are two main findings that are really the key towards diagnosing the CCG. And those two findings I have labeled here in red and green. The red line shows the RR interval, and the RR interval, as you can see, is more than 3 large squares. And what does that mean? That means that the heart rate is less than 100. And that, by definition, rules out the patient from having ventricular tachycardia, because ventricular tachycardia should have a heart rate of at least more than 120 beats per minute, which is not the case here. So this is not VT. Second reason why this is not VT is because the QRS complex is too wide. Now that seems like a contradictory thing to say, because VT is supposed to have a wide QRS, but not this wide. If you look at this QRS complex marked in green, it is as wide or a little bit wider than one big square. That is more than five small squares. That is more than 200 milliseconds wide. So that doesn't happen with VT. There are very few conditions that can actually cause this to occur on the ECG. And the number one, number two, and number three reasons why this can occur is because of hyperkalemia. And that is why the first thing that you have to do in this case is to give calcium gluconate plus or minus some bicarb even before the patient's lab results come back, because this is not a scenario where you should be waiting for the lab results to come back to prove that the patient is having hyperkalemia, because the patient really doesn't have much time left before going into cardiac arrest if this particular pattern is happening. Why people get confused is because hyperkalemia is not very well taught, especially at UG level. People only talk about the peak T waves, but in very severe hyperkalemia, and like in this case in which the potassium was 9, you won't actually get the peak T waves that much. You'll get a very broad QRS complex, also known as the sine wave pattern. So the treatment here is calcium gluconate, and synchronized cardioversion is out of the question because the patient is not really having tachycardia even. So that's not really a good option here. Amiodarone is the biggest mistake that people can make, because one of the reasons why hyperkalemia causes these ECG changes is because of sodium channel blocking properties, and amiodarone is a broad spectrum antiarrhythmic that also has some sodium channel blocking properties. So if you give amiodarone in this scenario, that is a great way to make the patient go into asystole. So you should not do that. And lipid emulsion obviously has no role in this particular scenario. So whenever you see this ECG, an extremely wide QRS complex, and is not really fast enough to be called VT, that is when you can consider toxicological and metabolic causes. So number one is hyperkalemia. You can also get it with TCA toxicity, severe metabolic acidosis, etc. That is why giving bicarb as well empirically might be a good idea. Again, if you give some calcium, if you give some bicarb and you actually got the diagnosis wrong, it doesn't really matter, because those things are very unlikely to actually harm any patient. So that is the big takeaway from this particular ECG.